Hey, everybody, it's Dr. Dana Gibbs. Today, I want to address a question that comes up really frequently, and that is, should people with subclinical hypothyroidism be treated? So people are very, very frequently told they have subclinical hypothyroidism, but that it does not need treatment. So, this problem is similar but slightly less common than what I discussed a couple of weeks ago, which is people who have normal TSH testing and aren't being treated for their low thyroid symptoms because their labs are normal. Um, all right, but first, if you're listening to this and you're not a physician, please keep in mind scientific proof is not nearly as black and white as people think. And in order to make treatment decisions for individual people, sometimes we have to consider evidence that's not as absolute as we would like. So, this is not meant to be individual medical advice, and you should consult your own physician for any medical issues or diagnoses we may have. All right, let's get into it. So, subclinical hypothyroidism is typically diagnosed with the same test that we discussed before, the TSH with reflex to free T4. So, a typical patient might be like this. So, this lady was 30 years old. She was fatigued. She was tired when she woke up. Her hands and feet were cold. Her body temperature was always kind of low. She had bloating and constipation, dry skin, irregular periods, reduced libido. She also had some adrenal symptoms: salt craving, lack of endurance, lightheaded when she would stand up too fast, loss of strength, urinary frequency, especially at night, and unable to recall her dreams. So we'll talk about that a little more later in the discussion, but that's not unusual for those issues to go together. There are even more complete listings of hypothyroid symptoms in some of my earlier episodes, which can all be found on my website, which is www.danagibbsmd.com. So, the difference between her and some of the folks I discussed earlier is that her TSH has actually started to rise to the point where it's elevated out of the reference range. So, that reference range for TSH is 0.45 to 4.5, and that's a very broad reference range. That's LabCorp's reference range. Um, so when you check the TSH with reflex, the TSH is, on her particular case, the high-ish out of the normal range between 4.6 and 10. But her free T4 is still within its also extremely broad normal reference range. And the technical definition of subclinical hypothyroidism actually also includes those two facts, but it also includes technically no symptoms. But somehow this fact gets ignored when we're talking about these patients. And the reason this person came in was due to symptoms. So it really ought to be called sublaboratory hypothyroidism, I guess. So recall that TSH is not thyroid hormone. It's produced in the pituitary gland as a signal to the thyroid that the metabolism has gotten too slow. And the signal, when it gets elevated, is a signal that the thyroid gland is not keeping up anymore. So free T4 is a measure of the free stored hormone T4 free in the bloodstream. So the reference range for T4 for normal is 0.82 to 1.77. So the upper end of that normal range is almost double the lower end of that normal range. So most of these patients are told that medication won't help them. And in my experience and in the JAMA US Expert Committee report, this is actually true if the medication is levothyroxine or any other version of T4. And many studies validate that treatment with levothyroxine does not really help these people. And for a large subset of people, it can actually make them worse. So, in fact, there are many studies that show these patients have poor life outcomes compared to healthy controls, treated or not. So, telling them that nothing is wrong with them, or nothing is wrong with you if you have it, is not actually true. So many doctors will try levothyroxine anyway, adjusting the dose up and up until the TSH is actually lower than normal. And even then, it frequently doesn't help. So the bottom line is that people with subclinical hypothyroidism are sick, but they're not sick enough that treatment with T4 alone will help them. Well, why are they sick? So they're sick for the exact same reason that we discussed in the prior episodes when we were talking about people who have hypothyroid symptoms and normal TSH. And that is that their normal T4 is not being adequately activated to T3, but instead is being shunted over and made into reverse T3 for one reason or another. And we talked about lots of reasons: stress, medications, diet, genetics. Those are a lot of them. Anyway, Hashimoto's disease is one more. So recall that T4 has to be activated to T3 in the body cells in order to stimulate your metabolism. And that reverse T3, if too much of that is being made instead of T3, will block the action of T3 at the level of the cell nucleus, even if the free T3 level is also within normal range, or even sometimes well within normal range. So what is the normal reference range of T3? Well, it's 2.0 to 4.4, also at LabCorp. So I have to say that I've really never worked up a patient who felt well with their free T3 down at 2.0, or really even at 2.5. So I somewhat take exception with the way that LabCorp got their normal subject sample to get their bell curve. So what is the solution for these patients? Well, the first one is to test all the labs. Test the TSH, test the free T3, the free T4, and then the reverse T3 and the total T3, so you can find that ratio of total T3 divided by reverse T3. And if it's lower than 10, then you have your answer. That means their reverse T3 is higher than it should be, high enough that their metabolism is not being sufficiently activated, and they're going to feel bad. So how do you treat that patient? Well, you start by supplementing with a little bit of T3 only until their free T4 level starts to drop and the reverse T3 level starts to drop. I like to see a free T3 level not get below 0.7, but not really above 1.0. So that's a lot tighter than that reference range, and it's in the lower end of the reference range for T4. If you go lower than that, they're going to start feeling bad in other ways because T4 does have direct effects in the body, and you need it. So these kind of patients are frequently afflicted with Hashimoto's thyroiditis and haven't necessarily been diagnosed. So it's a good idea to check for the antibodies to Hashimoto's as well. That's the thyroglobulin and the thyroid peroxidase antibody, and examine their thyroids to make sure they don't have nodules or anything unusual about the gland itself, and even maybe do a sonogram. So in Hashimoto's disease, their damaged thyroid gland is now damaged to the point that they are starting to make relatively less T4. And since T4 is what keeps your TSH in the normal range, once their T4 starts to drop, then that's when you'll see the TSH rise into that between 4.5 and 10 range. So when those people are treated, their ratio of T3 to RT3 should start to rise. And when it gets above 10, then you will start having to also give them a little bit of T4, because if you stop or you give them T3 alone, they're just not going to do that well. However, most people won't need nearly as much T4 as the standard doses of T4. All right, and the rules we talked about before also still apply. Rule number 1, whatever prescription is chosen, administer the dose divided twice or even 3 times a day for best results. to get the least fluctuation in the hormone levels in the bloodstream. So this lowers the peak level that you get with once a day dosing, which reduces the stimulus to make more of the blocking reverse T3. It also means that the lowest level won't be as low as if you only take it once a day, and people won't have as hard a time getting out of bed in the morning. Rule number 2, check the labs at the same time of day every time, preferably exactly midway between the doses. So 6 hours after the morning dose, 6 hours before the evening dose, if you're taking it twice a day, rather than right before their morning dose, when you will get an artificially low number on the T4 and the T3. Rule number 3, taking the medication at the same time every day matters way more than being 2 hours before and 2 hours after a meal. This is really just too difficult for people, and it frequently causes them to get up before they meant to, and it also causes people to miss doses because they go, "Oh, I just ate breakfast. I shouldn't take the dose." No, that's wrong. And it really isn't necessary. It matters way less than the effect that you get from dividing the dose. So, say you forgot your medicine and you just had lunch. Go ahead and take the pill. It's way better to absorb a tiny little bit less, like a 10% or less difference, than to not get any at all and feel like crap all the rest of the day. So, this rule applies no matter what kind of thyroid medication you're taking. So, how much T3 is a patient going to take? Well, they're going to take enough to get their ratio to increase about to 10 to 12 with an absolute level of free T of at least 3.5, but not out of the upper end of the normal range. So generally it's wise, and what I recommend is to start very small and titrate up to symptom relief. So half a tab of the 5 microgram liothyronine twice a day is the starting point. So 2.5 micrograms twice a day. And increasing the dose by 5 micrograms every week or so until you've gotten them to the ideal range. Now, I've really never seen anyone who needed more than 25 micrograms of liothyronine daily. And as a matter of fact, a lot of people will feel bad and start having trouble sleeping when they get up that high. So 10 to 15 is really a much more typical dose. All right. And you monitor the thyroid medication by checking those free hormone levels, total and reverse T3, in addition to TSH. And one final thing, even at these tiny doses, there can start to be problems when you start taking T3 because of anything that suppresses mitochondrial function, like chemotherapy, many antidepressants, amiodarone, contaminated generics, beta blockers. So these people may have trouble. Adrenal depletion. If a patient is really, really adrenally depleted, meaning they've got the fainting spells and the low blood pressure and they crave salt and they pee all the time because they can't hold on to their body's fluids, then you may need to do something else to address their adrenal depletion. So another issue is contaminated generics. So sometimes T4 can be contaminated with T3. Sometimes T3 can be contaminated with reverse T3. So there's a particular brand that I really like of generic. So you can go with the brand Cytomel T3 or liothyronine, or the particular generic that I mostly am happy with is called Sigma. Also, another issue that can cause people trouble when they start taking T3 is caffeine. So a lot of these people have been tired for a long time, and they may be taking really high doses of caffeine because they can barely stay awake. So when you start them on T3 and they get sweats and jitters and shakiness and can't sleep at all, then the T3 gets blamed. So what they need to do is slowly, as they taper up on the dose of T3. They need to half their caffeine and then half it again and then half it again. Eventually, they will be able to go back to having some caffeine, but right at the time when they're starting on T3, that is not going to work. So that's it for our topic for today. Just want to mention the clinician's course that I'm proctoring now is just about halfway done. We finished a 3-session deep dive on thyroid dysfunction, diagnosis, and treatment. Next, we tackled HPA axis and adrenal dysfunction. And now we're moving on to testosterone, men's and women's hormone replacement, and other deep topics in this nice Sunday lecture series. So we're getting from Dr. Alan McDaniel the latest insights into diagnosis and treatment, including how to properly use FDA-approved preparations and supplements to balance and optimize hormone therapy for men and women. We're continuing each Sunday afternoon through Christmas. If you want to join us, the live sessions are free, and the replays and slides and other supporting documents are also available for an administrative fee. You can find that on my sister website, which is www.allergyaccessmd.com/endo opt-in. All right, I'm Dana Gibbs. I'm an integrative physician in North Texas. I help people address thyroid and other hormone imbalances. You can find more on my website, which is www.danagibbsmd.com. So I'll see you next time on the Tuesday Live. Have a good evening. Bye.